Good afternoon, everyone, and thank you for that kind introduction. A little change of my designation. Dr. Shankar has become the principal from yesterday. From 1st July, I have stepped down as the HOD, so I'm just the professor of pathology at JIPMER. We have a rotational headship, so I am no longer the head of the department. In a way, that's a relief. And Dr. Vasuki, one thing. I want the light on there. All of you sitting in the back row, come forward. This talk is for you, the postgraduates and the residents. I don't really care much for who's sitting in the front row, but it's for you. So please step up and come ahead. We have to have postprandial. I don't want you to sleep. And consequently, if you start sleeping, I'll fall asleep. So you don't want that, right? So move ahead, please, and step up. You could have Dr. Vasuki, this light off. Yeah, I think that's fine. Is the screen clear to all of you? And before we begin, yes, a big thank you to Dr. Swaminathan. Where are you? For inviting me and Dr. Sandhya and your entire team is this too loud? It's okay? No, it's hitting my ears very hard. Okay. All right, thank you all very much for inviting me. And postprandial, I think we will not get into any somnolence, provided you are active enough. All right. Again, at the outset, I am thankful to my PhD scholar, Srirag, a part of whose work is going on, which will be included in today's talk. He helped me with this presentation. And what I'm going to discuss now is on bone marrow. I'm sure. Another little question I want to ask before I start. How many of you are familiar with bone marrow aspirations? Raise your hand high up. How many of you do trephiness? Only one? Trephiness? Yeah, I see a few people here. Bharanidhara and Lumen, I don't see your hands up for trephiness. Okay. So for most of you, I presume trephine biopsy is not a usual technique that you are doing. Yes or no? Okay, so we'll try and include that and get into of you to understand the whole process. Bone marrow trepanning, if you look at, or trephining, is an ancient procedure. It is there before Christ, BC. And that time, it's something akin to a burr hole that we do nowadays. Getting a piece of the bone or drilling a hole into the bone was an age-old procedure. Initially, it was because of probably as a cure for mental illness or other diseases. But in 1905 came the first work that has been published on the utility of studying the bone marrow. And incidentally, it was on a trephine biopsy and for diagnosis of leishmaniasis. It was published in a Russian article, a Russian journal. Subsequently, in 1929, the Russian pathologists, they described the technique of studying sternal puncture, that is, studying the bone marrow through a sternal puncture. And since then, aspiration has become a more preferred, a more easier procedure than a trephine biopsy. Bone marrow is one of the largest organs of the body. We are all aware of it. If you look at it, it composes of about 3 to 4% of your body weight, and most of the marrow is fat. So you know why your weight increases. There are two types of cells in the marrow, the hematopoietic and the stromal, and both have very important role to play. And there are basically two techniques, an aspiration and biopsies. Why do we need to do a bone marrow? This is an age-old question, I'm sure. As undergraduates, you've been asked, you've been shown the needle and explained, and without understanding anything. And over the years, the indications of marrow has changed drastically. When we were students, the first indication that you had to say was suspected case of megaloblastic anemia. Now, no one does a bone marrow for megaloblastic anemia. You have other avenues available. Okay, so let's see what are the common indications of doing a bone marrow. It's very important in unexplained anemia. When either the abnormal red cell indices come up, or there is cytopenia, anemia accompanied by other cytopenias, or even anemia with cytosis, increase in the other cell counts. So that's probably the commonest indication, and the word is unexplained. Please don't go ahead and do a marrow for a case of iron deficiency anemia. We don't do that. Second is when there is an abnormal peripheral blood smear which suggests a bone marrow pathology, one of which is cytopenia, teardrop cells, NRBCs in the PS. When you think that the pathology is dealing with the marrow, that's another indication. Of course, a very common indication is diagnosing staging of a whole lot of hematolymphoid disorders. Acute or chronic leukemias, MDS, the myeloproliferative lymphomas, plasma cell myelomas, amyloidosis, mastocytosis. So these are another group of diseases where we do a marrow. It's also investigation of suspected bone metastasis, bone marrow metastasis, unexplained focal bony lesions on radiological imaging, etc. Unexplained organomegaly, mediastinal mass. You're not able to really target the mediastinal mass or a retroperitoneal mass. Think it's a lymphoma, you can do a marrow. Evaluation of iron stores, we'll come to that in a while. Then of course the other indication is pyrexia of unknown origin, where to look for microorganisms or use that same marrow sample for culturing. Investigation of storage disorders, and currently with the increase in the transplant going on, for potential transplant donors to see that the marrow is all right, it may be done. What are the sites from which we do a marrow? Traditionally sternum was used, but no longer. We don't do sternal puncture at all for the problem of over-penetration and going through the sternum and because of its utility. So the current site is posterior superior iliac crest. All aspirates and biopsies are done preferably from the posterior superior iliac crest. It has a good representation of the marrow, and it is a safer procedure to do. In pediatric, that is very young children, up to the age of 1, we can do, because there is a lot of cartilage in the posterior iliac crest, the tibial tuberosity is a good site, especially when you do it in a child. Okay. There are 2 techniques: bone marrow aspiration with what was called the Salas or the Klimas needle, and a trephine biopsy using what is called the Jamshidi needle. So this is an aspirate. I'm sure all of you who have seen bone marrow aspirates on a regular basis, when you report out, you would be very happy with a field like this. It has nice cellular particles, lots of cells, and therefore an aspiration is very, very important. It's important because it tells you morphology. Morphology is much better appreciated in the aspirate than in a trephine. Trephine, it needs some kind of getting used to the morphology in a trephine. Apart from that, the aspiration is whole lot of, and this is what I'm going to concentrate on, how to go beyond morphology and arrive at a diagnosis. So you can do your immunocytochemistry on it. You can do flow cytometry, cytogenetics, molecular studies, even EM and culture. All of this can be done with the aspirated material. It's technically easy. Quick turnaround time. You do an aspirate, within 2 or 3 hours, the report is ready. All that you need is to make smears, get it dry, stain it, see it, and report on it. So that's it, as fast as it possible can be, and hence is more popular. However, at times we encounter diseases where the marrow is fibrotic, or it is acellular, or the lesion is focal, and what you aspirate out may not be representative, or the whole pathology is because of a problem with the bone. In such situations, we carry out a trephine biopsy. However, having said this, the current dictum is to do an aspirate and biopsy at the same time. Rather than do an aspirate, wait for a negative result, get a negative result, say that it's diluted, it's an only blood mixed, dry tap, and then again subject the patient to the trephine biopsy. It's not done. All those who have done marrows themselves would realize that it is a very painful procedure. No matter how much of anesthesia you give locally, the moment you aspirate out or when cut into the bone, it's a very traumatic procedure for the patient. So we wouldn't want to really subject a patient to that. So it's best to go in the same sitting. So these are the lesions where we need to do a trephine biopsy. An acellular marrow, you won't get anything out in an aspirate, or a fibrotic marrow, or the lesion is focal. That's what is this diagnosis? What should this be? It's a lymphoma with a nodular deposit, focal deposits of a low-grade lymphoma. So if you put your aspirate needle somewhere here, you're likely to get only normal cells. So in focal lesions, it's good to do a trephine. And this is a case of osteopathy, renal osteodystrophy, where the bone is destroyed. There is not destroyed, bone is damaged. A lot of bony lesion is there, osteoclastic, fibrotic lesion, so you won't get good material. So all of these are certain indications where you need to do a trephine biopsy. It's always good to do both together, but which one to do first? The concept behind that is, whichever you do, you're going to cause hemorrhage. Whether you do an aspirate first or a trephine first, whatever you do, you're going to cause hemorrhage, and that could lead to certain morphological artifacts. I prefer to do, or generally we prefer to do, a trephine followed by aspiration, because aspiration causes a lot of hemorrhage. So whatever you do, two things. Your entry into the skin is the same, but into the bone, you keep a gap of at least 1.5 to 2 centimeters when you're penetrating into the bone, and use the separate needles. Don't use a single needle for both the purposes. So that's how it is done. At times, if an aspiration fails, it's good to make imprint smears. Imprint smears are made by rolling the biopsy material onto a slide or touching it like a touch imprint. That's useful. So generally, again, when we do all the three things together. We have an aspiration, we have a touch imprint, and we have the trephine biopsy. So that it always helps. An imprint is very helpful when the aspirate is poor. Aspirate is, we've not obtained much cells. It's kind of a trailer, kind of a prelude to the trephine, if it's done well, and yield is often much better. Plus, imprint smears are good samples for immunocytochemistry. If you have to apply your immunostains, it's better done on an imprint than on an aspirate because the aspirate is hemorrhagic. There's a lot of blood and plasma there, so it might create problems. So it's good to do all your immunohistochemistry, please don't do it on an aspirate, do it on the imprint smears. At times it clots. I remember the first time I did a trephine biopsy, it was a patient of a CML, and I went in. Yeah, I'll take care. Thank you. I went into the needle, pulled out, and there was a nice long clot, the entire length of the bone marrow needle. I got scared, But then my senior was there with me who said, nothing matter. You put it into a formalin, use it like a clot section, and we get good material. So if it clots, you don't even get a good bone material, use it. It is often very useful. Processing of a trephine is slightly difficult. It has to get decalcified. We follow this Hammersmith protocol, which has been developed by the Imperial College London. And that is a very useful, quick protocol where we fix it with AZF, that is acetic acid zinc formalin. The fixative itself has a decalcifying acid. So it's good, within 24 hours you can fix it, decalcify with formic acid, and within 48 hours you can get a good trephine biopsy available on your desk. So you have a case, you've done the aspirate, next day or that same evening you can see the aspirate. Within 48 hours, you can get the trephine and have a look. That has really decreased the turnaround time. And this processing is good for staining, immunohistochemistry, or molecular, anything you want to do, it's possible. When you evaluate a bone marrow, it's important to note the clinical details. As always, most of the time you don't get much information, but still persist. Call up your clinician, say that I'm not going to report. We so many times put up report withheld, report rejected. If clinical details are not available, don't try and give information without getting. Morning there was this talk on maximum information and minimal things. So it's usually reverse. We get minimal information and we give them maximum output. No, that's not allowed. Maximum information, maximum output. That should be our policy. Always have your CBC and PBF findings with you. Have the reticulocyte, in case you're dealing with a hyperproliferative marrow, have the reticulocyte available, and this is very important. There are many institutions in this country where aspirates are reported by the hematologists and the trephine biopsy is reported by the histopathology section. And there is a big wall between the two. and they don't know what the aspirate report is, the other person doesn't know what the biopsy report is, it creates chaos. It's important to have an adequate bone marrow biopsy. Roughly when you go in and take out, approximately 2 centimeter if you can pull out, there is this 25% shrinkage that occurs. So it's good to have a adequacy is maintained also by 5 to 6 trabecular spaces. So I'm sure all of you are aware of this. How to report on the cellularity, that's the first thing we look at. So roughly, how do you assess cellularity? Roughly 100 minus age. So you need to know the age of the patient. Roughly it's 100 minus age, but that's not the hard and fast. Roughly a child up to the 10th or 12th, 15 years or so is about 80%. Beyond that, overall marrow cellularity for all of us is about 50 to 60%. It starts going down in the 7th decade. Okay, so this, if you would say, is, if it's in a child, it's a hypocellular marrow. So always comment on the cellularity with the knowledge of the age of the patient. This is a normocellular marrow if it's an adult. This is a hypercellular marrow. So a 70-year-old or a 50-year-old or even a 40-year-old, this would be a hypercellular marrow. Okay. So similarly in a trephine, it parallels very well. That's a child marrow. Notice that even in the first year of age, there will be some fat space. It's not that it is 100% even at birth. Some fat space will be there. This is an adult and this is an elderly. When you're interpreting a trephine biopsy, this is what we always look at. The first fat space, it's called. A normal marrow for age, whatever be the cellularity, will always have some fat spaces next to the trabeculae. If that is the point where cellularity starts. If it's to be hypercellular, this area gets covered first. So if you see this, whatever be the age, it's a normal marrow. Okay, unless this is obliterated, then you think of hypercellular marrows. So when you evaluate, these are the points that we note. Something similar to a synoptic reporting, we must comment on all these things in our report. Erythropoiesis, myelopoiesis, good to do an ME ratio right at the start. Megakaryocytes, plasma cells, lymphocytes, macrophages, reticulin of course on the trephine, iron on the aspirate. Look for other findings. These are what cells? The erythroid cells. That's in an aspirate. The nice erythron is formed and these are in the trephine. Erythroid cells in trephine biopsy look dark blue with a little halo around each of them. Shrinkage. The cytoplasm kind of shrinks. So these are all these erythroid cells. And this is the immature forms of the erythroid cells surrounded by mature cells. So that's erythropoiesis, normal. That's in an aspirate. That's in a low power of a trephine. Similarly, these are the myeloid population. Myelopoiesis starts always at the paratrabecular area. That's where the normally you won't find a myeloblast on a trephine. It's very few cells there. So you notice that the maturation is taking place like this. So that's a trephine biopsy and that's an aspirate. You are all familiar with the aspirate. It takes some time to get used to the trephine morphology. These are megakaryocytes on an aspirate, megakaryocytes on a trephine. Trephine showing lymphoid aggregates, aspirate showing plasma cells. So all cells are nicely visible on both the aspirate and the trephines. How many cells to count? This is again a perennial problem that we face. Many of us have this habit of counting how many cells? We do a differential on a peripheral smear, we count 100 cells. 100 cells in a marrow smear is maybe 1/100th of the number of cells that are present, so it's useless. Never ever do that. If needed, like if it's a case of an acute leukemia or a myelodysplastic syndrome or a myeloma, where you want to do an exact count of the blasts or whatever cells, count 500 cells at least. Once I was in reporting, we have this 5-headed microscope. So I asked a PG, he said, how many cells do you count? 100. I was angry. I said, 100? He then said, there are 5 of us. Each of us have counted 100, so we have counted 500 cells. Good logic. I couldn't answer that. But yes, as many cells as you can get, count. As many cells as you can get, count. Otherwise, for routine purposes, like, normal marrows or staging marrows, Just do a myeloid erythroid ratio. That's enough. You don't have to say that there are 21 metamyelocytes or 42 neutrophils. All that is, is not right. So just do a myeloid erythroid ratio. But when needed, depending on the case, do a 500 cell count. What stain is this? That's a Prussian blue stain and absolute necessary for all aspirates. Especially in our population, when the iron levels are generally low, it's good to do an iron stain along with your aspirate. And similarly, for most refined biopsies, it's good to have one reticulin stain and, if necessary, do a trichrome for collagenization. I'll come to this in a while in discussing the cases. I'll digress a bit and talk about something beyond morphology as to what is this microenvironment. There's a lot of work going on in understanding the bone marrow microenvironment and how it plays a role in the disease process. It's basically a supportive system and has all the cell types, not just the hematopoietic, the stromal cells. It is full of various cytokines and it is also that matrix proteins. And all this together is essential for the proliferation and differentiation of the hematopoietic stem and progenitor cells. Okay, so that's the microenvironment. These hematopoietic cells, they divide in an unsynchronized manner in resting condition. Some part of the marrow, they are proliferating, other parts, they are quiescent. And that's why the total of these stem cells remain equal. These stem cells are presumed to be localized to certain points in the marrow, not everywhere. And these are called the niches. Niches is the home where they go in. And these are the functional units which control their proliferation, fate, behavior. In a routine or a normal marrow, there are two niches. One is called the vascular niche and the other is called the osteoblastic niche. As the name suggests, the vascular niche is around the sinusoid. The osteoblastic niche is around the osteoid, on the bony front. The cells, the hematopoietic stem cells that are present in the vascular niche are the ones that are proliferating and differentiating. Whereas once they have proliferated and differentiated, they go into the osteoblastic niche where they remain quiet, remain for maintenance, and if necessary, they'll shift back to the vascular niche and start proliferating again. So that's the general concept, and this gets altered in many diseases. Currently, we are working on the microenvironment in CML, and we will hopefully find also that how the microenvironment is influencing the progress of CML. Imatinib came as a real magic bullet, as it is to be called, when it first came in the early 2000s. But now we are realizing that many of the patients of CML are also getting resistant to imatinib. And microenvironment of that individual, is it playing a role? So this is a cartoon that's very nicely made by Srirag. If we look at the vascular niche, it's catering around the sinusoid, and there are these two groups of cells, the perivascular cells and the CAR cells, which kind of organize the vascular niche for the cells. And this SDF, stromal derived factor 1, CXCR4, this protein combination, CXCL12, is what calls for the proliferation and maturation of the hematopoietic stem cells. So this vascular niche is rich in oxygen. Therefore, all the proliferation part takes place here. As the cells have proliferated and matured, they move to a relatively quiescent area which has less of oxygen but more of calcium, and that's where they stay. So this is normal. Okay, this is normal. This whole niche gets altered in many disease processes. Just one example, the stem cell quiescence in the osteoblastic niche, when they are quiet, they become resistant to apoptosis. Okay, so, and in many disease processes, apart from the osteoblastic and hematopoietic, the hematolytical niches, there are smaller niches that are produced by the cells which are away from these two areas. And the tendency of these cells is to go into those niches and avoid the drug reaching those places. Okay, so that's the whole concept, how the niches get altered by these various proteins. So CXCL12 and CXCR4 are interlinked proteins which play a role in disease processes. We will, maybe once the work is done, we will at a later date give you in more details of this. These changes, therefore, summing it up, CML stem cells can migrate to various niches and survive there in spite of imatinib, and all these processes are being studied and will be altered. Now, how do we study these microenvironment? There are many, many ways. This is one of the way is just a simple CD34, mean vessel density, and we can find out the niches of the cells. You can use IHC, you can use flow cytometry, and we are working on this by various cytokines and mutational studies to see the role of the diseases. Okay. Yeah, now let's take a little break and tell a little story about a little baby whose mother, a pathologist, has come back from work. Mama, what did you do all day today? She says, oh sweetie, Mama looked at slides all day. Did you look at swings too? She was thinking Mama is in a garden, in a play park and looking at slides, so she wants to look at swings. Mind you, we do look at slides, but we also have many such swings which help us in diagnosing a disease. So the next part, actually part is, what I'm going to do is try and see how these swings or the tools that we have help us in diagnosis. This is, all of us are familiar with, morphology, special stains. I'll talk of morphometry in bone marrow a bit. How flow cytometry is influencing our diagnosis, how immunohistochemistry influences, cytogenetics, the molecular PCR sequencing, and the culture. So we take up cases to say how we can go beyond morphology. It's not too difficult. At least we can suggest, even in places where we are not actively doing those tests, it's always good to be able to suggest the possible test for a diagnosis. So first we start with the colors of pathology, the special stains. So we have this 35-year-old man who is a chronic liver disease patient who presents with repeated bouts of hematemesis. He has ascites and spleen which is 3 centimeters below the costal margin. So what's the diagnosis? Clinical diagnosis? Chronic liver disease with, portal hypertension. So what do you expect in the peripheral blood in portal hypertension? Portal hypertension, splenomegaly, the molecular PCR sequencing, and the culture. So we take up cases to say how we can go beyond morphology. It's not too difficult. At least we can suggest, even in places where we are not actively doing those tests, it's always good to be able to suggest the possible test for a diagnosis. So first we start with the colors of pathology, the special stains. So we have this 35-year-old man who is a chronic liver disease patient who presents with repeated bouts of hematemesis. He has ascites and spleen which is 3 centimeters below the costal margin. So what's the diagnosis? Clinical diagnosis? Chronic liver disease with, portal hypertension. So what do you expect in the peripheral blood in portal hypertension? Portal hypertension, splenomegaly.
Thank you, sir. Now we request Dr. Devdatta Basu, sir, to give the memento to Dr. Alagason, sir. Thank you. Thank you, sirs and ma'ams.
Who is Crescent Cabrina? Hi. I'm not partial. Kamalakannan. You know what I did? Taking attendance is a very enjoyable thing. I'm going to miss that. So, all 4 of you be a little aware, because anytime I will call any name from this list. Who had a lesion on the chest X-ray, and we have a beautiful diagnosis, intrapulmonary spindle cell neoplasm. Sometimes our radiology friends give such diagnosis, I've seen, have you all seen spindle cell neoplasm? I wonder how they see these spindle cells. So the pathologist was very wise. He also said benign spindle cell neoplasm. Luckily the post-op was uneventful. But let us see what the specimen tells us. So that is the specimen. So this we can call it as a well circumscribed, firm, whitish, maybe faintly lobulated mass. And you can see some cystic spaces in the periphery. Bharat sir is gearing up, I know. He is gearing up for the answer already. The biggest clue is this, what I just told. In this histology, spindle cells are seen, but I am unable to see. When you don't know the pattern, you say sheets, right? Right, no? So I will call it as sheets. And there are some cellular and acellular areas, that is the margin. These are the cystic spaces. They are either blood-filled spaces or entrapped air spaces in the periphery, right? And these are your less cellular areas. So the comparison of the cellular and the acellular with this thick collagen and spindle cells. Shall I give you the IHC? It is CD34 positive, CD99 positive. Abhinaya, can you tell the diagnosis? No? Please stand up. You can venture any diagnosis. Pardon? Can you, somebody reiterate that? Pardon? DFSP. This is in the lung I was talking about. Anyway, because it is CD34 positive, she went for DFSP. Do you want any other immuno? I'll give you Pymentin. No problem. Another 500 rupees down the drain. Any other immuno anybody wants? Please sit down. Thank you. You are in the right track. Because spindle cell, no, we do S100. I don't trust this much. Not 100% anyway, although its name is S100, I'll trust it 5%. Maybe it's better called S5. Stat 6 is what sir wants. Since morning he has been talking about this. And it is positive. But this is lung. So Abhinaya, now will you?
Now we request Dr. Ramasundari Ilamvirai. Thank you, ma'am. Thank you, sir. We have various stalls installed near our hall. Kindly have it too. You are already provided with the index sheet in your conference bag. As you visit the stall, get it stamped. After completing your visit to all the stalls, put the ballot in the box kept near the reception area. 3 lucky draw prizes will be given at the end of the conference.
Let's have
IAPM meetings. Whenever we are getting the invite, we are neglecting the laboratory medicine. But once a postgraduate of MD pathology or MD microbiology or MD biochemistry comes out and he comes to the industry, the first question is that, are you able to manage the laboratory? And the answer will be 50%, 30%, 20%, and they say we are very comfortable with the microscopes. But as the young generation have been evolving, and we have to go beyond the microscope, and if we had carefully observed Dr. Devadatta Basu's lecture, The learning curve was that beyond the morphology, we have something else. So without much ado, I'll just go with that of the quality toolbox, what we can offer from the clinical pathology point of view. Now the laboratory is consisting of three things. The three pillars are the personnel, the process and the technology itself. When we are trying to have a laboratory, we require the people, we require the process, which also includes the equipments, and also what methodology and what process we do across. So the quality management system is new to laboratory in India. From 1990, we have been understanding what is quality management system in laboratory itself. But we should be proud that the quality management system in the laboratory is having a saga of around 75 to 85 years itself. So one of the most important thing in the quality management system is the quality control. Next comes the quality assurance and the quality system itself. Now these are the quality system essentials which are very, very important for any laboratory itself. We have organization, the personnel, the equipment, which becomes the most important part for the commitment. The purchasing, process control and information management, which becomes very important for processing the analysis of the things what we are doing in the laboratory. The documents, the occurrence management and the assessment is the next part, because whatever you have done with the help of purchase, whatever you have done as a process, whatever you have managed the information will be recorded as per the documents which you have provided. And if there are any complaints, feedback or is coming across the occurrence management. And if you're going for accreditations, which are the important part of the laboratory, then this becomes again the third tier. The fourth tier is that based upon the complaints, the feedback and the occurrence management, you excel in the customer service, you provide more facilities and safety, and there is a process improvement itself. So the quality management system, which we showed in the previous slide, which had about ingredients of about 4 into 3, can be simply made into 5M and E. 5M refers to man, which is the personnel, the machines are our equipment, the methodology, what we are trying to do, the materials, what we are going to procure. We require money to support these and also to support the environment itself. The phases in the laboratory quality implementation is very important. We have to go with the 4 steps. The first step is the proper management and the leadership of the organization. The leader who is going to be there in the laboratory should lead the team, and he should work in coordination to imbibe the culture of the culture itself. Next is the process of the laboratory has to be correct and safe, and education has to be done properly. May I ask the front lights to be switched off, please? Next, you have control and assuring the quality of what you have done in the process itself. That becomes very important. Next is the continuous improvement and the prepare for the accreditation itself. Accreditation does not mean that the laboratory is doing a quality work until unless you have a commitment from the leadership and the organization itself. Accreditation is just a paper what I'm going to do, but the habit of quality should be from every individual. You may not go for accreditation because of various reasons, but there should be quality culture in every individual in the team itself. The process of the quality assurance includes all the 3 steps which are included in the laboratory itself. That is the pre-analytical examination, analytical examination, the post-analytical examination. If the quality management is applied to all the 3 phases, then you are going to call it as a quality assurance itself. So the quality assurance cycle involves everything to produce what? A right result, right time, right specimen, the right patient. But if I am putting the control measures only to the analytical process, that becomes quality control. So you should understand that the quality assurance is application of the management system to 3 phases of the cycle, but the quality control remains only to that of the analytical part. From the laboratory point of view, the pre-analytical errors constitute about 60 to 70%, post-analytical constitutes about 10%, and the remaining which is controlled is the analytical errors itself. Now the errors do happen because of many reasons. So if you say inadequate attention to the detail, non-validated test, time pressures, lack of quality control, sample control is very poor, poor results verification, poor workload management, and lack of understanding of the training. Now, in any quality management practices itself, we should understand that the errors do happen every day. If the laboratory says that I don't have a mistake, I don't do an error, then the lab is dead. You should receive customer complaints. You should receive clinician complaints. You should get complaints from your colleagues. You should get complaints from your staff. If you're not willing to listen to those complaints, then you're not a good leader. Because the critics are more important when compared to the pally sugary coated words. That's very, very important. There are a lot of factors which influence the analytical variables. Now we are talking about the clinical pathology today, but you can apply to any part of the laboratory itself if you are interested in hematology or in flow cytometry or even in your HLA laboratory or cytogenetics or molecular biology. There are various factors which includes the variables. One is the reagent stability, integrity, and efficiencies. Very important is that we started learning that when a kit comes, I have to read the kit pack insert. How many of us have really read the kit pack insert to understand that what the manufacturer says? That's very, very important. Next is that the equipment reliability. You have specified your technical specifications, but this works to according to your satisfaction. Have you verified the machine performance in your laboratory? That is method verification. Next is procedural reliability and the SOP. Are your junior most technician doing the same thing what a senior most technician does? That's a questionability. Especially in the urine sediment analysis, only the juniors are posted. And they are given only the pipettes which are not to be used by the seniors. The seniors uses the automated pipettes, but the juniors in the staff uses only the pasture pipettes, which is not to be used. These are some of the examples. So I have already defined what is quality control. Quality control will be having predefined precision levels, and you're going to apply the statistical control to make sure that you are very near or within the standard deviation itself. The purpose of the quality control in laboratory and clinical pathology especially is to have accuracy and precision and to immediately detect the errors which may be because of the system failure, adverse environmental condition, or operator performance itself. So the difference between the quality assurance is the total system you are managing, and the quality control is the tools what you are going to control only the analytical data. Now a point about the external quality assurance is that when you are talking about the quality control process, you have two things. One is the internal quality control, the other one is external quality control. The internal quality control will measure the precision in your laboratory. You are doing every day in your laboratory. Whereas the external quality assurance will measure the accuracy, where you are getting a sample from a proficiency provider, you are testing it in your laboratory, feeding into him, and the report comes whether the reports are acceptable or non-acceptable. So that means the internal quality controls gives you precision, the external quality control gives you accuracy. I'll just skip some slides because of the time constraint, so let me not ponder much about it. So when you are trying to implement a QC program, you should understand whether it is a quantitative assay or a qualitative assays. In laboratory, you have got only two. You have quantitative or qualitative. Quantitative refers to the numbers. Qualitative refers to that of positive or negative. Urine comes under semi-quantitative results. So you are putting them in the qualitative assay itself. If you want to run any QC program in the laboratory, you should have a policy and a procedure for that. You should have responsibility to monitor and review it, train your staff, obtain quality control materials, analyze the data, set the target values, establish quality control charts if it is quantitative. If it is quantitative, you go with that of the LJ charts. But it is qualitative, you are going to pick up false positives and false negatives will be coming into that, and you're going to apply the 6 sigma in that. Next is the troubleshoot, and whatever you do in any of these steps has to be documented. So the phases in that of the implementation of the QC program may be very simple, but it takes about 3 to 6 months to imbibe the quality culture in our technical staff. So the quality system management should have a quality policy, you have a quality assurance program, and other aspects of the good laboratory practices has to be taken into care. Now today, with the purview of the quality control in the clinical pathology, I'll be talking more about the urine analysis and bit about the semen analysis itself. I'm not taking into the body fluids or to that of the stool analysis itself. So why we are working to that of the measurability? That is why we want to give positive or negative to the accurate value is that whenever your labs are following ISO 15189 document, this should be in 2012, I'm sorry for that error. So if you have got ISO 15189 document, that is the document which is given by and adopted by the global fraternity, which revolves around competencies and quality measurement in the medical laboratory. So any of the medical laboratory accreditation agency will follow ISO 15189 for their accreditation. If your laboratory is ISO 15189 accredited, or if your laboratory is following standards of the ISO 15189, though not you are accredited, the measurability of what you are giving is equal to global values what has been accepted worldwide. That means if a person who has measured blood glucose in Tirunelveli in an ISO 15189 practicing laboratory, the values will be plus or minus 5% if the same test is done in New York. That's how it means that the ISO quality is being assured globally. That's how we get into the good clinical laboratory practices. Now, as I told you, my talk will be involving to two scopes. One is the urine analysis, another one is that of the semen analysis. Semen analysis is a different talk and you can go for a day together. Urine analysis can go in for 2 days or 3 days. But my only intention was to just give all of you an idea that even a simple urine analysis requires quality control. So urine is undergoing physical examination, chemical examination, microscopic examination. This may be again a manual method or an automated method. Microscopic analysis consists of lot of crystals, cellular artifacts, as well as that of the cells itself. So the quality control, what I have divided for ease is that manual reading, automated analyzer. The automated analyzers can be classified into various ways: automated chemistry strips, automated flow cytometer, or it may be combined. Manual reading is by a dipstick method, or you might be using a machine in your laboratory, and you might also have here the strip reader may be automated, flow cytometry may be automated, but you might require some digital imaging to understand what the images show. So when you are having a manual reading or an automated analyzer, you should practice QC. So let's see how does it go. So when you have this QC procedures, what we do in dipstick, various vendors are available, especially with that of these vendors who are having what is called as urine analysis control levels 1 and level 2. Now, two types are there. One is a multi-use dipper style QC, the dropper style, and the dipper style single use itself. That means the QC material what you are getting for the chemistry examination may be a single use dipper. That is, you take a tube, you fill your quality control level 1, level 2, dip the sticks, analyze what is the value for level 1 and level 2. Level 1 is normal, level 2 is abnormal. Now when you have a dropper is given and you are doing individually this. So any of this are good enough, but you should know that the kit pack insert declares the expiry of these kits. So the expiry of the kits becomes a question when you are using this quality control. Now the quality control for the dropper style is having a short expiry period when compared to dipper stick or dipper style of QCs itself. These are available in India, people are using it. So we have to use the QCs for our strips itself. So level 1, level 2, I just got you to show that level 1 is normal, level 2 is abnormal. When you come to the automated urine sediment analysis, you have got barcodes where it has been read to that specific lots and the details are you are given. This is for the UF, that is for the flow cytometries, which you can do the sediment analysis, and chemistries also can be done on that. When you're using an automated machine, you'll be able to do a precision check with absolute acceptability with that of the cellular sediments itself. You might also get the LJ charts, because these are numbers which are given from your flow cytometric methods itself. So in crisp and short, you should understand that urine analysis do have control materials, whether it's manual or automated. If it is automated, you might have a quantitative analysis of the sediment where you might get an LJ chart. And whenever you open the QC bottle, I should understand that when is the expiry date after opening the kit vial, where I am going to store it, whether I am going to freeze it, I am going to do a refrigeration. Most of the QC materials for the hematology as well as the urine analysis should be stored in the refrigerator between 2 to 8. Do not keep the QC control materials in the door of the refrigerator because the temperature is not aligned. Now, whenever you are doing a urine analysis, okay, you cannot have an external quality assurance program for your manual methods because urine is very sensitive and within 6 hours you might have the deterioration. So you have to do split sample testing in your laboratory at least monthly once, depending upon the volume of the urine what you're doing. When you're doing the manual IQCs, what we call internal quality controls with that of an inter-comparison between two technologists, you should try to control the chemistries as well as the microscopy. That means if the blood is positive in the strips, did I see RBCs in the microscopy? If leukocyte esterase is positive in the strip, did I see WBC? If protein and albumin is positive, did I see cast? If nitrates are present, whether the culture was positive. So this is very important to correlate even in our day-to-day samples. And if you are seeing any discrepancies, then you have to do a root cause analysis by why you are having a discrepancies itself. In an automated machine, you have a cross-check where you can control the blood chemistry to that of the RBCs, similarly to all of the parameters which you can do it if it is automated. So this is a correlation with the chemistry and the micro. You have got here glucose, protein is positive, blood is over 3 plus or 4 plus, then you have got leukocytes, and there's a scatter plot from the flow cytometer which shows that bacteria is present, which is the magenta color. So in the urine, the simple fact what we should take home the message is that there are controls available. I have to run it every day, document it. Inter-laboratory comparison has to be done, or you have to do a split sample testing. What is the split sample testing? The same sample you are giving to 2 technical staff and you are masking the ID. When you are masking the ID, they do the test, you compare the results and you say that it is acceptable. So that is the split sample testing what you are doing. Now coming to the semen analysis. Semen analysis itself is now taken up by the andrology labs. Most of the IVF laboratories do have andrology labs, but still semen analysis becomes the gamut in the clinical laboratory which is serving the multi-speciality hospitals. Now the semen analysis has to be analyzed as per the new WHO standard which has been released in 2020, and it is the 6th edition. The 5th edition has been given up, and now it is the 6th edition, and all the reports has to compile with that of the WHO standard 2020. Methods is the new ISO standard for the semen analysis, and it's a beautiful booklet which has got 10 annexures where you have got templates of the QCs which you have to adopt. It's very simple, and you have to go through it to understand that the semen analysis has to be done so meticulously. In any manual semen analysis methods, the most important thing is this: the motility, the concentration, and the morphology. Now, when we lack the motility, concentration, and morphology, the QC becomes to a toss. And most of the time, the motility, concentration, the morphology, it's simple test, but we ignore. It's always said as simplicity is elegant, but to get on to the simplicity, we have to strive. So similarly, today luxury is that offline is luxury rather than online. So what are the common errors when you are doing a sperm motility, specimen handling, manipulation, counting, microscope, and multi-key counters? I don't read everything here, but I wanted to highlight only this because most of the time when a technician brings a newborn chamber filled with the diluted semen, we only count approximately. We don't give heart and soul to that specimen itself. So most of the errors happen in the counting, and that's why subjective bias is giving an overestimation or underestimation. Calculation errors are common. Spermatozoa are counted along the edges of the cover slip. Improper or inappropriate use of motility assessment equipment, including our chambers, what we are using. Next is the multi-key counters. We always use the hemocytometer counters. You have either 5 or you have got 7 for counting your Newbar counting chambers, which has to be avoided. There are sperm motility counters which are available, which you have to adapt in your laboratory. Now coming to the semen concentration itself, again you can classify into 3: specimen handling, counter and counting chamber, pipettes, microscope, and multi-key counters. The most important thing for me is the pipettes. Laboratories work around pipettes, and if I am not doing a proper pipetting, any of your tests will go wrong. Similarly for the semen analysis itself. So if you are thinking that why there is an Eppendorf stall, you should think and go back to the Eppendorf stall to learn about the physical anatomy as well as physiology of the pipettes to understand how the pipettes work. How many of you did the pipetting today? I did it. How many of you did it? Raise your hands. Only 4, 5. That's bad. Please go and work on the pipette. You will really be happy to do that. Especially if you want to do manual immunohistochemistry, or if you want to do manual immunofluorescence assay for the kidney biopsies, or for your immunofluorescence assays for the autoimmune disease, only if you know pipetting you can teach your technician. Friends, I'm telling you, pipette centrifuge is going to be there till your death. You have to know the calibrations of the pipette, calibrations of the centrifuge, how to pipette it, what are the pipetting errors, why do you get irregular values when you are doing the same sample analysis. If you are not doing, you are missing something in your life. So pipetting is very, very important. Next is microscope. When you're talking about the microscope, how many of you know about the field of vision? Raise your hands. What do you mean by field of vision? Can anyone say what is field of vision? Is it magnification we are talking about? Yes, sir. The area. Okay. So he attempted to see the area seen by that of the objectives and the eyepieces. Which one? Objective. Okay. What value will you take it as field of view is correct in medical practice? Okay, if you go back to your microscopes and see each of this, you have got two numbers. One is the magnification into 4, into 10. Below that, you have got decimal numbers, 0.18, 0.20, 0.22, 0.24. This 0.18, 0.20, 0.22, 0.24 is the field of vision. What you have given to your technician will be having a field of vision of 0.18. What Nikon microscopes or what microscopes you are using in your professional will be having 0.22 or 0.24. Now, which field of vision is bigger? Pathologists, what you are using is 0.20, 0.24 is having a field of vision bigger. So, the technician says, I saw 20 RBCs in the urine sediment per HiPA field, but his field of vision was 0.18. So, it was smaller. But when it comes to you, the same slide, you are saying it's not abnormal because for 0.20, you are saying it's okay. I am not seeing so much. So that is the difference you are getting in your semen analysis, stool examination, and urine analysis. The field of the view matters a lot. Simple things, but go back and you think whether the field of view is same as the technical staff and myself before you report that what he did is right or wrong. Now coming to the counting chamber, most of the counting chambers what we are using, the Newbar counting chamber is from various manufacturers. It's not calibrated. So when you are not calibrated and measuring equipment, and because of the repeated usage, the protein debris gets into the grooves, and when you are charging, some of them leak out. So you will not be able to do a proper counting either for the urine sediment or to that of the semen analysis itself. So these are the common errors. As a pathologist, we should be able to take control of it. Coming to the last one is the sperm morphology. So sperm morphology, we all know that we do a Leishman stain or a Pap stain and we are going to assess it. But when you are doing it, are we doing properly the counting of the spermatozoa as well as that of the pore staining has been controlled by our technical staff. Now in this, the pore staining technique, two things you should understand. Whenever you are ordering the purchase, you get the dyes, you get the stains. Please see that the company remains the same. Most of the time, the purchase changes the vendor. They say that vendor 1 never provided, so I'm going to give you vendor 2. The vendor 2 quality of the dye may not be right. It may not be working to you as it worked out for the second one or the first one. So you should be very careful when you are buying on to that of the reagents to understand the staining and why you get a poor staining technique itself. So I think with this I'll stop, and you should understand that the normal morphology has to be understood by us before training on to that of the technical staff. There is what is called as American Association of Andrology. There's a training course for every pathologist who can take up for the basic semen analysis, and once you complete, you get a certificate. So that certificate will assess the competencies because it has got virtual sites where you can count and you can assess yourself whether you're doing a proper counting or a morphology itself. So this is the morphological assessment as per the WHO which has to be done. The abnormals, normals, abnormals, what you're going, the head shape, then head comments, you have to give mid-piece comments, principal, overall, and all this. I don't think I'm doing it in my lab. So the best way to make sure that the manual semen analysis starts to be converted into automated semen analysis itself. So can anyone say what is the probable cost of automated semen analysis? Just a guess, in lakhs or crores. Any guess? It's not more than a lakh. It's not more than a lakh, and you should understand that it's available in India. It's available in India, it's made in India, and just we require 5 minutes with a computer to get the whole lot according to the WHO format. So there are people who are marketing this in the business. Please explore. Please do not ignore the vendors. Whenever the vendors are coming or whenever the vendors are available for you to talk, please go ahead and talk about the technology to them. They may be useful to you in coming days. So when you are talking about the semen analysis, difficult to have quality control in your manual process. Automated process, he gives the beads. He gives the beads for your control itself. So you should be very familiar when you're doing with that of the manual semen analysis. 2 people has to handle the same semen analysis to give the morphology, the concentration, and the motility, and the average has to be released. So this is the internal quality control for the semen analysis for both the manual methods as well as for that auto analyzer which is available. I think that I'll stop with it. I'll be available for whole of the banquet if anyone wants to discuss about the quality control measures or you want to host a quality management system course in your laboratory, in your medical college. Please do contact me. I'll be very much volunteering to do this for a whole day program for the quality management system itself. Thank you very much.
Thank you, sir, for giving us an informative session. We request Dr. Swaminathan, sir, Professor and Head, Department of Pathology, Tirunelveli Medical College, to honor Dr. C.N. Srinivas, sir. Thank you, sir.